Good morning, good afternoon, good evening, everyone. Welcome to our plenary session 4, which is also the final plenary today. Today we have 3 very interesting presentations plenary, and the first one will be conducted by Dr. Kumnuan Ungchusak, and who will give us a talk on the communication aspect and in terms of many aspects of policy communication, health emergency. Dr. Ungchusak is a former FETP director of Thailand, and he's also currently the advisor to Department of Disease Control, Ministry of Health in Thailand. Dr. Ungchusak is a well-known public health scientist. We are very looking forward to his presentation today. Dr. Ungchusak, the floor is yours.
Good morning, good day to everyone. Thank you so much, Philip and the organizing committee. I'm very honored and very happy to join the family of FETP and TEPHINET again. The topic I would like to share is that the many aspects of policy communication in health emergencies. Next, please. My key message is that the training about policy communication is not so adequate in the FETP. This is according to my experience. Second is that the persuasion of policymaker is the art and is also the science. The third one is that if we want to persuade decision makers, we need to know who are the key players, our friends and our foes. And then the fourth point is that crisis situation can happen from the threat or from the wrong response. And in this case, I would like to share the example in Thailand, which is related to the long response and how policy communication play roles. Next, please. I remember that in 1986, I joined the first FETP, regional FETP meeting in Taiwan. It's very, very nice experience, very nice city. But you know, as a trainees and as a staff, we are very, very worried because we are taught how to make a perfect scientific writing and presentation. We try to rehearse the presentation 10 times or 20 times. I remember we did not have enough time to sleep. We cannot go out to enjoy a nice city of Taiwan. We just keep doing rehearsals because make presentation in the scientific meeting is the ultimate goal that you need to make a perfect. But for policy communication, it's totally contrast, totally different. You don't need a long talk. You just make very brief executive summary. Normally you don't make it persuade in the meeting room, but in every opportunity you can. And then normally the making decision during the crisis is not official. It is non-official approach. Next, please. One of my trainees asked me about this slide, and I never know what is this one. I never learned about this, but finally, when we have more experience, we know that there are 4 directions of communication. The first one is scientific evidence-based orientation in the not direction. The opposite direction is the interest-based. This is not evidence, but talking about human rights, talking about money, talking about the economic return. Yes. On your right hand side, external. If you want to approach externally, you go to the public, or you go into the internal approach. So this 2x2 table, as FETP always use 2x2 table. If you focus on the evidence base and you make your persuasion internally, we call advice. Most of the FETP are doing this advice. But if you use scientific evidence, but you go outside, you talk to the media, and that we call advocacies. If you do it external, but you don't emphasize on scientific, but you emphasize on human rights, equities, something like that, we call activism. You are making social pressure for making decision. But if you turn to the lobbyists, they use the internal approach, and they are not talking much about evidence based. They are focusing on interest based negotiation. What are the political popularity? What are the money return? That is the dark side of persuasion. Most of them are the dark side of persuasion. But remember, in crisis, people use lobby, internal, and use interest based. And I will share with you. So I learned from my trainee. They asked me, what are these? I cannot explain them 10 years ago, but now I'm very clear about that. Next, please. So this is the third COVID wave in Thailand. The first wave, we did it very well, and we are very proud that Thailand are the best. We do it very well. The second wave happened in the migrant workers, but we still control it very well because it is the original strain which spread not so rapid and not so severe. But for the third COVID wave, starting in April this year, we are terrible handle this, and that is a very great crisis, and we learn a lot. If you can see this graph, we normally we have 0 report cases, and the number of infected is not more than 2 digits. But starting for the third wave, the infected new cases 2 digits, 3 digits, and 4 digits. We have 1 death before, but finally it's go to 2 digits, 3 digits, and 300 cases a year. Not a year, a single day. And Bangkok and metropolitan are the major hotspot, and you can imagine it's the capital city is in crisis. So every province is in crisis as well. The COVID spread from Bangkok metropolitan area to 77 provinces in a very rapid time. Next, please. So, crisis in this third wave come from the Delta variant, which is very high speed spreading and also severity. But our response is the major factor of crisis. We have outbreak after outbreak, cluster after cluster in Bangkok and 5 surrounding provinces. We have cluster in construction working camp. Most of them are migrant workers, and we are very cannot handle that. We have cluster in export food factory and computers. So the business sector are crying that they need vaccine. We have cluster in market, and people cannot go to the market to buy food where they are very afraid. We have cluster in low income community. The governor and the leader of the community asking for vaccine. We have cluster in prison, 400 prison around the country, and the cluster after cluster, the justice minister asked for the vaccine, spread to every province. So every province asked for the vaccine. We have hospital breast crisis. We need to construct a few hospitals, and people dying outside the hospital. They have to wait 2 days or 3 days. They cannot get the testing, and they die at home. So the death case increased from less than 10 to 50, and then to 100 and to 300 per day. Trust is eroded. Government still insists that there is enough vaccine. Don't worry, we have enough vaccine. But next, please. The vaccine is very well planned. Before the third wave, they have a very good plan. They want to immunize 50 million people by the end of the year. They will start with 17 million priority group, healthcare and frontline worker, 1.5 million, people over 60, 11 million, and people under 60 with comorbidity, 6 million. They want to complete this in June and July, 2 months. And then they go to the other population. This is very well planned, but when crisis happen, your well plan can be delayed, can be totally, messing up. Next one, please. So certainly there is vaccine shortage. There are listing for vaccine among different political parties to gain popularity. The Minister of Labor, who are the party A of the main government party, they want the vaccine. And as you know, the labor group, there are young workers, and this is not the high risk. The Ministry of Health, Party B, they also have they want to divert some vaccine to some particular group. They take care of the tourism sector. So the agenda is to divert the vaccine to the tourist sector, tourist province. We have Minister of Education. They want to open the school, so they want to give vaccine to every student, every university. We have business sector asking for vaccine for their factories. One of our big company who produce the beer, that lobby the government to allocate vaccine for their several 100,000 employees. So, but we only have 5 million vaccine per month. It's not 10 million as we forecast. We depend totally on our local production, AstraZeneca, and it's just start running. So this is not according to the plan. So vaccines are diverted from priority group. The elderly, the comorbidity, did not receive the vaccine, and that is why so many people die. Next one, please. Who are key players? The Prime Minister, as the Chief of Emergency Committee, he has the totally power, declare emergency. So every making decision go to the minister, Prime Minister. But all the political parties are lobbying for vaccine from the Prime Minister. They not go to the meeting. They go directly talking to the Prime Minister and ask the Prime Minister to give direction to the vaccine. We have the vaccine committee, and the vaccine committee cannot do nothing because it's an emergency committee. Okay, we have academic who always are talking about which vaccine is better than another vaccine. It's not the coverage. They are focused on the best, but not the most. We have business sector who have very powerful talking to the politician, and we have public and social media trying to get some news to the public. Next, please. So after we discuss with our trainee who are in the high position in the government or in the ministry, but they can do nothing. They have to pass this to the minister, to the government, and it's a very long process. So finally, there is one opportunity because it's in the crisis. So people ask, what are the options? So I and my friend have the chance to talk to the media. So we just go state there are only two options. First one is go like this, and then you will see the number of cases and number of deaths go from thousands go to thousands, or you get it back to the main strategy. But doing this is not enough. You open the option to the prime minister through via the media. So the media have to ask the prime minister, what is your opinion? And at the same time, you need to get consensus from the academic, talk to the infectious society, ask them to agree with the plan. You talk to the dean of the medical school, they are very loud speaker. The prime minister listen to the dean, not to the minister. And you also talk to those who are against the idea. The business sector, they have some idea that vaccination to the young age population is protecting the elderly, and this is not scientific. So we have to talk to them. We talk to the Thai commercial chamber, and they understand, and they say that okay, they will get consensus from the manufacturer society. We ask advisor to the prime minister to convince prime minister because we cannot reach them. And then somebody coined the term vaccinate the 608 is similar to the 7007 James Bond. We use this code, vaccinate 60 years old and 8 comorbidity. And then last, we have to show the results, because one that follow you, you need to provide the results. And we cannot sleep. We looking forward to the result. Next, please. And this is the evidence base. What we are trying to persuade is that most of the bed crises are elderly people. If you have 100 people infected from our data, 12% will die. But if you have in the 18 to 40 years old, you have 100 people infected, only 0.1 people die. So let the vaccine go to the elderly and to the comorbidities. Next, please. And we have to show the results. We started in the Bangkok metropolitan and the borderly. So you can see that in July, the coverage in this 608 elderly and comorbidity group is very low, and then you have a high number of deaths each day. But once you speed up the vaccination until you get to 55%, then you see some plateaus. 2 weeks from that, you see the plateau and the number of death is declining. The crisis of beds is reducing. Next, please. So I would like to conclude that prepare is very well. Handle emergency, you have to prepare, prevent, detect, and respond. Good plan can be delayed. Don't overlook this. Once you see the crisis and your plan is collapsed, identify the problem, causes, and prepare. Seek support evidence, but not too slow. You need to provide the evidence within half an hour or 1 hour. You don't have enough time to do modeling. You just very simple calculation. If the vaccine efficacy is 70% or 80% to our death, and you can making this coverage, how much you can save life. You can finish that within half an hour or 1 hour before going into the media room. You propose the option. Don't propose only one option. Always propose two options. The status quo, the current option, and your another option, and project the consequence. If you cannot talk to the government, to the prime minister directly, you go to the public or social media. If you cannot go by yourself, you ask your colleague, your alumni, your friend to do that. And you need to gain more support for the agenda with friends, and don't forget your foe, because they will hurt your agenda. Try to expand your sphere. Finally, do it both formal and informal process. So I would like to end and my presentation, and love to hear from other and from the floor. Thank you so much.
Thank you, Dr. Kumnuan, for a very interesting presentation. I think this kind of scenarios actually apply to each and every country in the world, similar in Taiwan here. But we try our best to stick to principles of public health and talk to our politicians and also media and key players about necessary measures to be taken while considering the interest groups' ideas. Try to balance between the two. So we'll have all the Q&A after the three presentations. At the moment, please, if you want to raise your question, please write your question in the Q&A tab, the chat box, and we'll gather all the questions and finally address those questions by the speakers. So next, I would like to say I'm very honored to invite Professor Stephen Peng-Lim to give us a presentation also in this plenary session about communication. Professor Lee is a senior consultant of the Infectious Disease Research and Training Office of the National Center for School of Public Health, National University of Singapore. He's also a very distinguished medical epidemiologist, and his presentation today is entitled Emergency Response Communications, Ethics, and FETP Role. Professor Lee, now you have the floor.
Thank you, Philip. Hello, everyone, and thank you for this opportunity to share at the plenary on communications, ethics, and equity in public health emergencies. The backdrop is COVID-19, and today I will share Singapore's experience on emergency response, including the policy, the communications, and the ethical trade-offs in handling the pandemic. Next slide, please. I think this slide depicts the global COVID situation of late, and the trend continues to be worrisome, especially in the Northern Hemisphere, which is approaching the winter. Okay, nearing 2 years now, there is no end in sight to this pandemic, and the first trade-off that we have experienced in public health is between lives and livelihoods. Okay, lockdowns, they have been helpful to buy time, but they actually also do not solve the problem, and they actually disproportionately disadvantage the lower socioeconomic groups. Next slide, please. Here is the COVID-19 cases and deaths as reported by WHO. You can see that we have experienced waves of this pandemic virus, and the latest waves can be attributable to the Delta variant. Next slide. From the weekly COVID cases and deaths by WHO region, we can see that the pandemic goes in cycles that are asynchronous in the different regions with waxing and waning, okay? And in this context, managing uncertainties and risks has become very much part and parcel of the public health practice. And we are dealing with a virus in a world that is very volatile, politicized, and complex. So the environment is not very good at this stage. Next. The global COVID cases in Asia are also of concern, because you can see here that we are the fastest region in doubling time for the numbers of confirmed cases, 173 days. And we think that this is attributable to the high population density that we have in Asia, as well as the urban congestion. And this could have increased the transmission potential in our region. Next slide. In Singapore, during the pandemic, for the first time in a long while, Singaporeans saw a transient period of empty shelves in the supermarkets. And this was because of panic buying. So the questions that come to mind are, what insecurities are playing and how can we be sustainable managing community fatigue and vulnerability? And here I would address or highlight the second key trade-off in this pandemic handling, and that is between safety and security. They may sound the same, but actually some people may feel safe and yet not feel secure. So what is the difference? If you look at it from the community angle, safety perhaps could be seen as the freedom from danger, but security is more than that. It has also to do with freedom from fear. And unfortunately, there was a lot of misinformation that has been generated during this pandemic with infodemics and distrust building, that we are actually facing two crises. The first crisis is a crisis in public health, but the second crisis is a crisis in public confidence. Next slide, please. So here you can see panic buying that's occurring because of insecurity. Now, every country is unique, and there are therefore social cultural determinants that trigger panic and anxiety. The key for each country is to identify and sustain a strategy that combines vaccination with testing, with contact tracing, with hygiene measures and safe distancing in a way that works for the country. And soliciting public confidence and trust building through communications is a vital component in this aspect. The problems with risk communication will have to do with how can we address the different attitudes towards societal response and resilience. Next. Singapore's local COVID situation is presented here as at 18 October. And one of the issues of safety versus security is that people have to decide for themselves, and the authority has a responsibility to provide the factual information as a trusted source. This is an example of real-time information that goes out daily in Singapore. And you can see that on this day, we have a cumulative total of 150,000 over cases, and of which 125,000 have been discharged. But that means that there have been 25 that are still actively being managed, and the distribution accordingly, some have been taken care of at community isolation facilities and home recovery programs, whilst the rest are in the general hospitals as well as in the ICU. Next, please. The close monitoring of hotspots of activity, known as clusters, is also an important component in the messaging. And here you can see the active clusters that are being monitored. Next slide. And the daily confirmed cases in Singapore. The past month has not been very good, and you can see that of the 25,000 cases over the past week that have been reported, about 88% of them are in the community acquired, and 11% involve dormitory residents comprising our guest workers, while the remaining less than 1% are imported infections. Next, please. How did Singapore get to this situation? You look at the locally acquired community cases, I would say that we experienced a series of unfortunate events. The contributory factors were firstly the Delta variant. This has confounded us because this virus has a very short incubation period, less than 4 days, sometimes even 1 day compared to the original strain, which was about 6 to 8 days. And the reproduction number of this Delta variant is also much higher at about 6 compared to about 3 in the original strain. So over and above that, we also had experienced perhaps a premature relaxation of the necessary control measures as we had moved from phase 2 to phase 3. And with this, the Delta variant probably seeded into the community, and we are facing the consequences now. Finally, we are also observing a vaccine paradox. Because of the vaccination of our local population, the patients that get infected with COVID and who are vaccinated tend to present with either mild or no symptoms. And this actually produces difficulties in our contact tracing effort. So in a way, we have become a victim of our own success. Community concerns related to safety and security need to be addressed urgently. Next slide, please. And now we move to emergency response. You can see my colleagues here who are contact tracers working in an urgent race against time. And the third trade-off here that we experience in public health is between responsiveness and responsibility. The two are both needed in public health, and they manifest as timeliness and accuracy of information. To be responsive, we need to be timely, but to be responsible, we need to be accurate in the information. And we often, in the heat of an outbreak, experience conflicts of interest in these two areas, and we need to find a balance that can work for the effectiveness of control measures and the benefit of the community. Next slide. If I can share here, 2 episodes of outbreaks that we have experienced recently. Unwelcome events as they are, outbreaks will occur from time to time and represent natural experiments from which we can derive valuable information about disease control. This first example is at a major market and hawker center where we embarked on a case control study of the risk factors in 46 of the 93 confirmed cases and a number of controls drawn from various lists. Next slide. The significant study findings showed up as being vaccinated having a protective effect compared to those who are unvaccinated. In addition, those who had used surgical masks compared to the use of non-surgical masks, and also the having visited or working at the fruit stall was a risk factor. So these findings yielded some very interesting perspectives on the behaviors of our local population. Next slide. The visit or work at a fruit stall as a risk factor was in fact something that sparked our interest because the other two were quite intuitive. We studied further the setup of fruit stalls, and I believe this setup is quite universal to our experience in many countries in this part of the world, that they are quite closely packed, and the patrons of the fruit stalls, they tend to come forward without proper queuing, and they will touch the fruits and produce to find the best ones that they select to purchase from the hawker. Now, it is due to the high-touch shopping habit for fruits and the ability of the virus to remain on the surfaces of the fruits that we believe fomite transmission had occurred at this market and food center. Next. You can see here that the social measures that we tried to introduce following our investigation were related to controlling the spread related to the fruit stalls. And here we have introduced the option of pre-packed fruit items, and then also making hand sanitizers available at the fruit stalls and putting up posters on hand hygiene and hand wash areas where to go to, and implementing a queue system of some sort. In the future, when the hawker centers are renovated, we will probably also have to review the physical setup for better crowd control. These are over and above the improving vaccinations and use of surgical masks for the market and stallholder patrons. Next. So you can see that outbreak investigations form a crucial element of field epidemiology in identifying causality and informing us for subsequent management steps. So in our second outbreak, this occurred at a popular restaurant where there was a cluster of a super spreading event involving 62 cases with secondary household transmission. Next slide. The significant study findings here were related to staff and patrons, okay, having mask-off activities, not just when eating or drinking, but also when they were socializing with each other for prolonged periods. And then there was also the vaccination issue. And interestingly, we found some environmental risk factors as well. And having visited the food display counter and having exposed to some items of food were also implicated in this outbreak. Next. This outbreak highlighted was actually preventable if we had introduced some timely measures. And we recognize that social behaviors, because of COVID fatigue, are quite hard for the community to observe in a responsible way. And you can see that although mask wearing is required, you can see that they are not very compliant with the proper way to wear the mask here. Next slide. So the other issue is vaccination status, and this finding supported the policy for differentiation of patrons at the food and beverage outlets by vaccination status. So today, only patrons who are vaccinated can sit and eat at our food and beverage outlets. The industry also has to introduce routine rostered testing for their staff. Next. So knowing the importance of vaccination, you can see here how the global vaccination campaign is playing out today. And there are some countries like the UAE, which has achieved near 95% universal vaccination, where there are other countries like Ethiopia and Nigeria, which are still at about 2.5% vaccination rate. This is the fourth key trade-off in public health: equity versus equality. Equity is defined as the quality of being fair and impartial, while equality is defined as the state of being equal. And these are again coming up as examples of equity issues that we are confronting in the public health pandemic. Another example of an equity versus equality issue is the lockdowns, because these lockdowns always disadvantage the poorer and lower socioeconomic communities. Next slide. In Singapore, we have expanded strenuous effort with the vaccination program, and the difficulties now are with a small segment of the population that persists in not wanting to be vaccinated. Okay? It is unfortunate because amongst the fatal cases, it has become quite evident from our data that the comparison between the non-fully vaccinated with the fully vaccinated patients, they suffer 0.9 versus 0.1 per 100,000 fatalities, which is a 9 times increased risk in those who are not fully vaccinated. Next. Finally, I will touch on the fifth key trade-off, and that is COVID zero versus COVID resilient. And here I would like to express the precautionary principle, which is very common in public health. That is that when we are dealing with uncertainty, we should err on the side of caution. It would have been fine if we could have a very fast resolution to the pandemic, but this pandemic has persisted for 2 years, and we have to also consider, okay, whether we can truly achieve a COVID zero at what cost versus a COVID resilient situation. And in this regard, Singapore has decided that COVID zero is not an option that is available. So how can we move towards COVID resilient? Next slide. This is the journey that we are transiting now, and we are actually uncertain and in fact feeling our way as we move across. And we have entered a preparatory stage in this transition journey where we have introduced 4 key enablers in which we hope will help us achieve the COVID resilient state, which is vaccination, testing, community-based care, and social responsibility. Next. The stabilizing of our local situation requires us to introduce a number of new measures, which, because they have come out so rapidly, has also resulted in comms nightmare and also confusion. So these are the booster vaccination strategy, the home recovery program, simplified health protocols, and a safe reopening of our borders. I will touch a little bit on each. Next. Firstly, the booster vaccination strategy. And this one, studies have shown that boosters do in fact work. So there is a progressive targeting of at-risk populations in consultation with the National Expert Committee on COVID-19 Vaccination. And their recommendations have been accepted by the Ministry of Health, and we are receptive to new studies and new findings as they evolve. Next. The second is the home recovery program. Because it is not an option for mild patients to be filling up all our hospitals, the home recovery program has been introduced and is suitable for most cases, okay? Especially the younger and vaccinated individuals. They move out from the hospitals into the community and recover at home. Next. The third is simplified health protocols, and these have been simplified to the best of our ability: what you should do when you are unwell, what you should do when you are well but you test positive, and what should you do when you have been identified as a close contact of an infected person. And hopefully this will reduce the stress and congestion in hospitals. Next. And fourthly, the safe reopening of borders. We are trying vaccine travel lanes with a number of countries and are hoping that this will allow, okay, a progressive reduction of border restrictions for all travelers from both sides over time in a safe and calibrated manner. Next. So in summary, from pandemic response to a resilient approach, we have introduced and are continuing to introduce public health measures, moving from a pandemic disease view of COVID to one that is now perhaps better understood and more manifesting like a flu-like illness. And this transition requires us to undertake a few balancing acts between key trade-offs, which is between lives and livelihoods, between safety and security, between responsiveness and responsibility, and between equity and equality. Okay, so policy, communications, and ethical concerns, they are all needing to be balanced in this approach. Next. The challenges ahead will not be easy, and sustainability is a key consideration. Okay, we need to build a whole of society approach that can tackle the crisis, and government and people have to work together to strengthen trust through good relationships. Next. In conclusion, with the emergency response, what will success look like? Well, rapid epidemiological response to epidemics can protect against pandemic threats. Good communications is important to break the chain of transmission in an outbreak and prevent recurrence of the situation. And lives versus livelihoods and multiple ethical challenges still factor into the disease prevention and control. At the bi-regional level here, we are cautiously optimistic at turning the corner collectively. And I wish all participants here blessings and success in your public health mission. Thank you very much.
Thank you very much, Professor Stephen Wee, for giving us very good examples which have occurred in Singapore and leading our way out of the pandemic. We'll come back to the Q&A session, and I believe there will be many questions for your presentation as well. Thank you very much once again.